Welcome to this short presentation on the neurological examination. This presentation will focus on the assessment of motor weakness and fatigability. One of the things that we all lack in the clinic is time. It's very difficult to do a full neurological examination, dermatomes, myotomes and reflexes. It can take 40 to 45 minutes to do, which most of the time we don't have. As orthopedic physical therapists, we usually just need to do a motor and sensory screen to assess for a deviance from normality, in which case we can refer. We can do a much shorter exam and achieve the same result. A good resource here is the 4-Minute Neurological Exam by Stephen Goldberg. It's a skinny book, it's a cheap book, and you can find it on Amazon.com. We begin with observation. Observation is critical. Watching someone's gait, we can look for asymmetry. We look for deviation to the left or the right, indicating any ataxic or cortical tendencies. We can look at the pelvis to see if there's any shifting in the pelvis from left to right or any obvious weakness patterns. We can also particularly look at the feet to see if there's any slapping or any excessive rigidity, which may indicate hyper or hypotonic cases. We also should look for atrophy. When there's peripheral nerve lesions, muscles atrophy typically very quickly, particularly in the lower extremities and in the feet and in the hands. A functional test that is becoming extremely prevalent these days is the 6-minute walk test. The 6-minute walk test has normative values prescribed for all ages and genders, and we can use this test to predict when somebody may be weaker than what would be expected by comparing the normative values to actual performance. There is good literature now that correlates fatigability in particular to the results of the 6-minute walk test. Although not quite as strongly correlated in the literature yet, there is some evidence beginning to demonstrate that fatigue and ability in the upper extremity can be correlated with results from a 6-minute UBE test. This is fascinating information that is increasingly coming to light. Once observation and functional testing has been completed, we can then move to functional testing such as the single limb and the double limb squat. Watching people do this repetitively, we can quickly identify deterioration in performance that may be consistent with fatigue. This is an excellent way to fatigue some of the larger muscles in the lower extremity. We can also do a heel raise test bilaterally and unilaterally, which combined with observation of atrophy can also lead us to the same conclusion. These tests should be done as part of any neurological screen. For the upper extremities, we can incorporate the push-up, either on the floor, as the young lady there is doing, or up against the wall if it's thought that the patient can't handle the full prone push-up. Most patients should be able to handle at least one of these positions, and again, it is an excellent way to pre-fatigue the body. Once this functional and observation testing has been completed, we can then move on to the reflexes. Reflexes can be done with a hammer. The typical ones are the patella tendon, the Achilles tendon reflex, the triceps and the biceps. And you really don't need to do anything outside of these. People can have hyperreflexia or hyporeflexia as a normal situation. What we're looking for is asymmetry of reflex behavior. That is the most critical portion. We'll also perform upper motor neuron testing here, which consists of the Babinski and the clonus reflex. The Babinski reflex, seen in the top right here, is where the sole of the foot is stroked by a relatively noxious object. The long end of the reflex hammer is perfect. And we're looking at the behavior of the big toe. We want to see big toe dorsiflexion to indicate that there is a Babinski sign. Babinski can be normal in both the very young and the very old. However, when it is present, it may be indicative of an upper motor neuron lesion of an acute nature. Clonus is produced by putting the patient into a mid-dorsiflexion range and then increasing quickly the movement into dorsiflexion, looking for a repetitive and reverberating flexion-extension movement at the ankle, indicative of presence of a clonus sign. 2 to 3 beats of clonus can be perfectly normal. We can now move on to the motor testing itself, and we're simply looking here at the efficiency of the contraction. Is the motor unit recruitment sufficient to maintain the contraction of the muscle fibers? We can't affect the muscle fibers themselves, and we're not testing the size or power or output of the muscle here so much as we're testing the output of the neurological system. The refrigerator analogy can really help us to understand exactly what's going on with the muscle system here. When we open a fridge, the light should turn on inside. If it does not turn on, we usually suspect that the globe is not working, the filament's busted. We replace the glove, the fridge turns on, all is well. That's analogous to an interrupted physical muscle fibre. A muscle is torn or it's strained, it doesn't produce as much output. We heal the muscle, the strength returns. If it doesn't, then we begin to suspect that we have a problem with conduction. And in conduction in this case is when we'll look at the cord, the power supply, the circuit breaker, and restoring those will produce the fridge working again. And this is the same with the muscle. We're looking at recruitment. Can the nervous system recruit enough fibers and motor units for the muscles to produce its full output? In this case, you can see the results of 3 manual muscle tests held over 8 to 10 seconds. In the red one, we can see a normal muscle. There's a build-up to a full contraction, which can then be maintained for an indefinite period of time. The weaker muscle is shown in the green, where the contraction can be built up, but it doesn't get to its higher point, although it is consistent. So in both of these, we have consistency. There's consistent weakness with the green. In the fatigable, or the neurologically weak muscle, we can see the production of the blue line, where there's a relatively rapid build-up to a full contraction, but because of recruitment issues, the muscle contraction can only be maintained for a short period of time before severely dying off, and the contraction rapidly diminishes over time. This is changing weakness, which we identify as fatigable weakness. Upper extremity myotomes are typically tested. We'll usually focus on the deltoid, the biceps, the triceps, the wrist extensors, the wrist flexors, and the intrinsic muscles of the hand. These will allow us to look at the most commonly affected segments, which tend to be C5-6, C6-7, and the C8-T1 nerve roots. Again, remember to look for atrophy, particularly in the hands. In the lower extremities, we'll typically focus on the quadriceps, the hamstrings, the gastrocnemius, the extensor hallucis longus, the dorsiflexors, and the perineal everters and the inverters. Some of the easiest muscles to pick up are the feet, particularly the perineals, the inverters, and the everters. The extensor hallucis longus and the dorsiflexors also are very sensitive to neurological changes. Why should we be concerned with findings? There are a few things that we want to look at. If we find a unilateral, isolated, fatigable weakness that can be explained by the signs and symptoms, then we typically are not very worried. However, if we find fatigable weakness at more than one segment, or we find it bilaterally, then that is a cause for considering a referral or a discussion with the referral source at the very least. When we do find a positive fatigable weakness muscle, we should always check additional muscles supplied by that segment to help us ascertain whether or not it is actually fatigable weakness or just a statistical anomaly. We should also take care to measure the difference between consistent weakness and changing weakness to identify the difference between nerve root compression and peripheral nerve palsies. It's important here to note that we should be consistently and constantly re-evaluating neurological signs. When neurological signs are present, they should at a minimum be reassessed at every patient visit, and you would usually tend to see patients at a more frequent level in order to make sure that we are keeping an eye on the neurological changes. One final point is to note that healthy people typically have healthy neurological systems. Most people we see don't have neurological problems. People who do have neurological problems tend to have fairly locally isolated neurological issues in one segment on one side. However, unhealthy people tend to have general neurological issues. So don't forget the overall global functional tests such as observation and our 6-minute walk test and the UBE and the big functional movement test. Those will pick up the vast majority of the issues that we're looking for. Thank you for your time on this presentation. I hope you found it useful, and we will see you in future presentations. Thank you.